All right, folks, welcome. This is a very special episode of Hennepin Airway. We have been really excited to share these results with you, and the embargo has officially been lifted as of today. So we are here to talk about the RSI Trial put on by the Pragmatic Critical Care Research Group, also known as the PCCRG. Do you want to talk about and kind of introduce what it is?
Sure, this is a research question that our network and others have been interested in for decades. It's one of the last big remaining questions without adequate evidence in emergency intubation, and we want to know the effects of Etomidate versus ketamine on mortality, as well as other important outcomes like hypotension at the time of intubation. And ketamine and Etomidate are the two most commonly used medicines to induce rapid anesthesia in our patients before intubation, and they're of course paired with a paralytic to give ideal intubating conditions. And we have our own practice at Hennepin, and what we've been doing for years. We generally use Etomidate more often, but of course ketamine has a big role in our practice in procedural sedation, post-intubation sedation, so we're certainly familiar with it. So we were very interested to participate in this big randomized trial.
Yeah, and it was a really important question for the community because, way back in the 1980s, Etomidate was shown to actually be super harmful for people who were on Etomidate drips in the ICU because it causes adrenal suppression, and people were dying as a complication of receiving Etomidate. So we know it's bad as an infusion, but what has been kind of an understudied question since then is whether it's dangerous if you give a single dose of Etomidate, especially to people who need their adrenal glands, like people in shock or sepsis. And so there's been a lot of observational work over the years about which is better, Etomidate, ketamine. A lot of conflicting results there. But there's been a number of analyses that have shown that Etomidate is more harmful as a signal for increased mortality, especially in sepsis, which has led to many institutions not allowing Etomidate, even some countries giving strong warnings against Etomidate based on this observational data. But could it be that doctors are just giving Etomidate to sicker patients, and that selection bias was not able to be accounted for in the methods? And that's why, because of that uncertainty, that's why this rigorous randomized trial is so important for us to learn, are there big differences between ketamine, Etomidate mortality, and blood pressure, and post-intubation cardiovascular collapse, so we can learn what's the safest way to take care of our patients when we're intubating them.
And mechanistically, they're both intravenous anesthetics. Ketamine is a dissociative agent. Etomidate is an anesthetic by class, but it does block 11-beta hydroxylase in the adrenal gland, which is why you get the adrenal suppression. So that makes sense, but we just don't know if that single dose makes a clinically significant difference. Ketamine, it's been heralded as this magic drug that never causes any hemodynamic collapse. I think that was a bit overblown in the past couple of decades, but it does inhibit, like NMDA receptors is how it works to induce anesthesia, but it does block calcium channels on the heart and everything else, and we don't know if that has a clinically significant effect either. So.
Yeah, exactly. So I think there was true equipoise because they both have pluses, both have minuses. There's this uncertainty of which one is best, which one is safest. There's there's strong opinions in social media, but I think we're really lacking some rigorous data.
So prior to this study, what was your guys' general approach to RSI in the ED or ICU for a sedative choice?
We at Hennepin, we mostly use Etomidate. We were really familiar with it. It seemed very safe, very low rate of cardiovascular collapse that we could attribute to the drug. It seemed to work well. So that was, we did use ketamine occasionally, but Etomidate was definitely our drug of choice. I don't know about the ICU, Matt.
Yeah, I have total equipoise for this question. I think they're both effective rapid sedatives. And before this trial, I didn't know really objectively which one had a more favorable profile.
Mm-hmm.
So we were really excited to do this trial and certainly see the results when the last outcomes were collected, and to see it presented today at the Critical Care Reviews meeting in Melbourne and published simultaneously. The New England Journal of Medicine is just speaks to what an important question this is for everyone who interacts with patients undergoing intubation.
Yeah, so I guess we talk about the methods of the trial. Like, what did we actually do? So we were one site, but there were a total of 14 sites, 6 emergency departments, 8 intensive care units, who were all participating in this trial, randomizing adult patients who are being intubated to either receive a ketamine for the sedative or Etomidate for the sedative. But it's pretty practical. There wasn't too many exclusions or special
And it's medical only, not trauma.
That's a good point. So this was medical patients only. These results, we don't know if they're going to apply to trauma patients. But basically all medical patients, unless the doctor thought, hey, this patient needs ketamine or this patient needs etomidate, basically we're able to enroll everyone else and kind of really see what this is like in a broad group of medical patients.
And in a true pragmatic fashion, the trial didn't dictate the dose of these sedatives, and we'll show you data on dosing in just a minute, but that was left up to the clinician, as was all other aspects of the intubation procedure. So the only thing the trial was studying really is what's the effect of ketamine versus etomidate as an induction agent.
And the big outstanding question in the community was, do patients die more often? So the primary outcome is mortality, which I think is really appropriate in this case because there's a really plausible link between the drug received, especially when you're really sick, and your 28-day mortality. So that's the primary outcome. But anytime you give any medication to someone who's being intubated, there's the risk that it's going to change your hemodynamic status, your blood pressure, your cardiovascular collapse, your shock index. And so that's a really practical secondary outcome that this study examined because if someone has more cardiovascular collapse, that means you're going to have to do more things for them in the peri-intubation period, and you obviously want to keep them as stable as possible. So those are the two big outcomes. Of course, there's a whole bunch of other data points gathered here to paint us a big picture, which you guys can probably find in the full manuscript, but we'll focus on those 2 points today.
And they were not blinded to what they were giving. They were told which drug that they should use. They got to select the dose, but the clinicians were not blinded. It was both pragmatic as it could have been. So,
yeah, and sometimes you can run into blinding, biasing outcomes. But since it's mortality, it's a pretty hard outcome.
Right.
That's not it. Cardiovascular collapse is also pretty firm outcome, but maybe a little bit more susceptible. If one clinician thought that one was going to be more likely to cause cardiovascular collapse, perhaps they would preemptively treat it. I don't think that's really a big plausible risk in this study that we think one is worse than the other, and so we're going to be ready with norepi more often with ketamine than with etomidate or vice versa, but that would be a potential risk.
And then pre-randomization, we should just say that this was one-to-one patient level randomization, and like our other Airway trials, we used opaque randomization envelopes that were right at the bedside. Clinicians were the ones enrolling in these trials. And should mention the envelope had dosing recommendations, varying low recommended and higher dose of each sedative. So the clinician could refer to that if they wanted, but they could also choose whatever dose they thought was appropriate for the patient.
Yeah, exactly.
And then the trial, as was pointed out in the results presentation, was funded by an offshoot of our federal government, PCORI, and was done with an exception from informed consent, which we have a lot of experience at Hennepin enrolling in that context, and that went smoothly at our site.
Yeah, so this exception for informed consent is a really important mechanism to study, interventions for people who are not able to consent, people who are really sick. So we are still able to improve their care. There's a lot of extra safeguards. So in this case, each one of the sites went into their local community and publicized the trial, got feedback. There was a panel of patient investigators who met routinely to talk about the trial and give their input and see what results were important to them, how they wanted them presented. So it really was a study designed to be patient-centered.
And these study designs are only allowable in two otherwise equal treatments. Like, we didn't know which one was better, which one was worse. There's equipoise in between. We wouldn't subject somebody to something dangerous, obviously, if we knew about it.
Yeah, exactly, 100%.
We covered a lot of the methods. I guess the analysis of the trial was intention to treat, as these large pragmatic trials should be. The trial was adequately powered, we feel like. The sample size target was over 2,300 patients. That would give us 80% power to find a difference of 5 percentage points in mortality between the two groups, assuming that about 30% of patients in the etomidate group would die in the hospital based on prior research. So I think starting the trial, we're very comfortable with that, and we'll look at how close the results actually match the planned power.
So that's kind of the background methods. I think it's a super important question. I'm excited to talk about the results here. But I think the first thing we talk about is the patients that were enrolled. Do these look like patients we see in the ED and the ICU? Are they sick enough that this question is still important? And I think the answer is a resounding yes. Just looking at table 1, it's a good split between ED and ICU patients. A huge number, actually 10 and 11%, have adrenal insufficiency or on steroids. So, that definitely represents a sicker cohort. And importantly, 45 and 47% of patients in each group had sepsis or septic shock. That's over 1,000 patients of the 2,365 that had sepsis. So a huge subgroup, which allows us to figure out if ketamine and etomidate have a difference in that subgroup.
And that's the big group that etomidate is the concern.
Exactly. So like historically, sepsis patients and etomidate is the big question. That's the big question. So now we have just a subgroup of this trial, which is bigger than essentially all the other ketamine and etomidate trials ever done, or close to it.
And we'll mention that the average age of these patients was around 60 years old, about 40% were women, and then there was a pretty even split between the ED and the ICU in terms of enrollment. So I think for generalizability, this trial results applies to medical patients in both those settings.
Totally. And you can see about 20% were getting vasopressors at the time of enrollment. So, pretty sick group, I think, not just your average patient being intubated after a Friday night at the bar. Looking at the intubation procedure itself, you can see that patients got their allocated assignment. So the people who were assigned to ketamine got ketamine, people who were assigned to etomidate got etomidate, except for just very rare exceptions.
Which is really, really good.
Which is really good for this Pragmatic trial, because these are, clinicians who are screening for eligibility, performing the enrollments. Oftentimes there's not research personnel at the bedside. So to have this high fidelity to trial group assignment built into clinical care, just so we can learn this question as clinicians, I think speaks to the PCCRG group. Rocuronium succinylcholine, there's a mix there that matches with modern day practice. Everybody got pre-oxygenation as we would expect. Looking at what laryngoscope is used, the vast majority are using video, which is great after learning the results of the device trial. And there's a mix of tube and stylet and bougie, which varies by operator and by site, but at Hennepin we like the bougie. That's not what this trial is about though. So let's jump into the dosing for ketamine and etomidate. I don't know if Aaron, you want to talk about that.
So talking about dosing, looking at figure S2 of the supplementary index, it shows the distribution of the doses. The recommended dose of ketamine is the thick dotted line, and that's 2 milligrams per kilogram. And in the trial, the average was 1.68, I believe, milligrams, 1.6 milligrams per kilogram, which is pretty close. And then the recommended dose for etomidate is 0.3 milligrams per kilogram, and the actual dose used on average was 0.28. So pretty in line with things, although we had it falls in line with what we do at Hennepin. I think most of us use around 20 milligrams of etomidate or 0.3 mg per kg, and ketamine can range from 1.5 to 2. So
yeah, I think this jibes with what we observe in real clinical practice, which doesn't always mirror what the FDA recommends, but I think this represents what people do in the real world. All right, so after we've talked about the intubation procedure, the drug dose is delivered, I think we can just talk about the primary outcome.
Yeah, and this is an exciting time because this represents over 10 years of work, a lot of planning, and then a lot of hard work on the behalf of the clinicians at these 14 sites to really, I think, give a definitive answer for this question, at least in the emergency setting. So the primary outcome was in-hospital death by 28 days, and we're comparing 1,176 patients who received ketamine to 1,189 that got etomidate. And what we can see is that the in-hospital mortality was very similar between the two groups, not significantly different. And in the etomidate group, it was 29.1%. And remember, the trial was powered to 30%. So that really preserved all the power of this trial to find a difference if there was one there. But at the moment, we'll look at the survival curves, but this absolute mortality difference of less than 1% shows that these two treatments are essentially superimposable when it comes to mortality. So looking over those first 28 days, we're presenting here actually a figure from the supplement of the paper that we think really drives this point home, because this isn't just in-hospital mortality, it's death at any location by 28 days following all these patients up. You can see these two curves are superimposable. So no mortality difference between ketamine and etomidate.
Yeah, so death in any location by 28 days, essentially identical, which I think is super interesting based on, some countries putting warnings on etomidate, other hospitals not using it at all. And we look and we see they're basically interchangeable. Mm-hmm. But I guess the natural question is, what about the subgroups? That's always, for any clinician, that's always a question. But like, well, sure, in general, you can use whatever you want. But when I see a patient with sepsis, I'm really careful to make a decision that's really customized, individualized to that patient, which is great if we actually know if there's a difference in those patients or not. And that's what's shown here in this forest plot. And you can see anything to the right of that vertical line, the point estimate favors etomidate. Anything to the left, the point estimate favors ketamine. But you can also see the error bars. For no subgroup is there any difference at all. And interestingly, in sepsis, for the 1,000 patients with sepsis, the point estimate favors etomidate. Doesn't mean etomidate is safer. The error bars definitely cross that vertical line, but the point estimate favors it. So there's not even a signal that ketamine is safer for patients with sepsis, which I think is interesting. And you look at the rest of the subgroups.
And just to say that one more time,
Yeah.
Etomidate doesn't kill patients with septic shock when it's used for induction in a single dose.
Yeah.
I think that's very clear from this trial, and that's a really important takeaway for my practice in both the ED and the ICU.
And so when we think about all these observational results, again and again, showing an association with etomidate and mortality, I think we can say that it's probably because the doctors trusted etomidate so much they would use it in the sickest patients. They would preferentially use it over other drugs when someone had a blood pressure of 50, 60, their peri-arrest. And we couldn't fully account for that with statistical techniques. So, which is super interesting. It's a good lesson in general for interpreting observational data. Let's see, so we should move on to the secondary outcome here, which is again, super interesting. And this is really relevant to us as clinicians. What happens immediately after giving these drugs, performing the intubation procedure? Is there a difference in cardiovascular collapse, which is defined here as just between intubation and 2 minutes following intubation? Was there a difference in vasopressor use, in hypotension, like a systolic less than 65, or peri-intubation cardiac arrest? And you can see in these figures that ketamine has 5.1 percentage points higher cardiovascular collapse at 22.1 versus 17.0.
And when you say vasopressor use, that's either initiation of a new vasopressor or increase of a dose of a vasopressor. And that also includes push dose pressors as well.
Exactly. So starting a pressor, push dose pressor, having to ramp up the dose of the pressor in the 2 minutes. This is just in between 0 and 2 minutes. So this is like an acute change. And that's, or new systolic blood pressure less than 65, or cardiac arrest. And you can see this figure outlines it nicely. The biggest difference is driven by vasopressor. So someone's pressure dropped enough that the clinician said, I got to treat that. A little difference in systolic blood pressure. Not a big difference in peri-intubation cardiac arrest, but that's part of the composite. I think it shows, this is a big difference. I didn't see this coming. Did you guys see this coming?
Not in the ketamine group, no.
Yeah, I mean, what we know about ketamine already is that it does have some endogenous catecholamine release, probably in a single dose. Maybe that helps it be hemodynamically neutral in the operating room, for example, when patients are there electively and pretty healthy. But I think you could speculate that people whose catechol stores are relatively depleted and are exposed to ketamine, may show hypotension, and that could be why this was exposed. I also don't think that the difference in this composite secondary outcome driven by clinicians using vasopressors is a weakness. I think those of us who do this a lot would be really uncomfortable with our patient's systolic blood pressure getting as low as 65. And so we would intervene with a push dose vasopressor or some other way to treat that hypotension before it gets so severe. So what if you look at a systolic cutoff of 80 instead of 65, and that's shown on the same figure on the right here, and the same conclusion should be drawn. Here it's a 6 percentage point difference in that composite cardiovascular collapse outcome, favoring etomidate with less collapse.
And a bigger difference in hypotension when you define it that way with the post hoc definition.
Yep.
Yeah, I think you're right. I mean, like clinicians are acting, here you can tell they're acting just to prevent some major problem. So it does seem legit that vasopressors is not just some sort of fluffy surrogate outcome. Yeah.
And we'll get it. We want to look at the rest of the results, and I think we should touch on our discussion around how important is the secondary outcome when the overall mortality difference wasn't seen, right? So let's come back. We'll put a pin in that, come back to it.
Yeah, definitely. This, again, highlights the secondary outcome by showing hemodynamics before intubation, at the time of giving ketamine and etomidate, and then in the 2 minutes after. So this is actually a pretty interesting graph. So the top graph shows systolic blood pressure. The bottom graph is percentage of patients receiving a vasopressor. So you can see that etomidate had a lower blood pressure to start barely, I mean, no statistical difference. They also had more patients receiving vasopressors in the hour enrollment. Again, no statistical difference, but a point estimate difference. At induction, similar story. But just within 2 minutes following intubation, the systolic blood pressure for people getting ketamine is lower and they're getting more vasopressors. So they're starting at roughly an equal point, and pretty quickly having some problems. And I think this is interesting because ketamine, as many people are taught, is a very neutral drug, or maybe because it's hypertension. That's not what we saw.
Yeah, I mean, I think a big take home from the trial is this difference in cardiovascular collapse. And this just nicely shows that this can't be explained by some fluke of randomization where the ketamine group happened to start with a much lower blood pressure and the difference was there from the get-go. This is clearly a separation between these two groups in between intubation and 2 minutes after.
Yeah.
And remember, these are etomidate and ketamine groups, but because the trial was done so robustly and there were not appreciable crossovers, this is the effect of the drug.
Yeah, 100%. And just looking at all other outcomes, we're not going to discuss this line by line. The most important ones are the primary and secondary outcomes. But you can see, just to highlight under additional procedural outcomes, the successful intubation on the first attempt, about 86% in each group. Now, this is a rigorous definition of first attempt success. It requires a single pass of the bougie tube and a single insertion of the blade. But I think it shows that we still have room for improvement. I don't know, Aaron, I mean, even in the pre-hospital space, what sort of first attempt success do you expect?
All over the map. I mean, nationally, between 40 and 97.
Yeah.
Like, it's just kind of all over the place.
But when you're training your medics, you have a special group of medics that perform RSI, what expectation do you have? Like, what should they get?
So, I mean, comparing it, I mean, the pre-hospital space is not our stabilization room, in which we're in the high 90s for. My goal was at least 90%. We started at mid 80s and went to 87, and now we're at 95 so far this year in 2025. So doing okay. A lot of practice and being able to watch the videos and stuff we can correct a lot of the technique stuff that helps. So for our supraglottic use for RSA, it's 99% first attempt. So
yeah, I think it just shows that I don't think it's detracts from the trial, because first intubation or successful intubation on the first attempt is not a key outcome here, and it's no different between groups. But I think it just shows that even though we have all these great tools, there's still some room for improvement in first attempt success. If paramedics can get mid 90s in the pre-hospital environment, which we know is more challenging, I think we can do better in the hospital too. So other safety outcomes, vasopressors at 24 hours, interestingly, was point estimate was a little bit higher for Etomidate, but the other outcomes were not significantly different. So I think this is probably a reasonable point to talk about how do you interpret this finding, the secondary outcome. There's more cardiovascular collapse, but there's no difference in mortality. So should we still care about that secondary outcome, even though, in the long run, it doesn't seem to matter? So
should I care about some initiation of vasopressors in the ketamine group if it doesn't translate to anything bad?
Yeah. You could make an argument for it. I don't know. What do you think, Matt?
Well, I mean, overall, I think that my takeaways are the trial was really well done. It had separation between groups, and it very clearly showed in an appropriately powered and sized trial that there's not a mortality difference. And we should mention that the way research through PCORI and this trial within our network worked is patient investigators were involved in the design and monitoring of this trial as it went on, and they clearly identified that mortality and severe hypotension were important outcomes to them. We get hung up on first attempt success and already discussed it a little bit, but that's certainly an intermediate procedural outcome. So I think that what Brian has taught me through the years is that a reasonable goal for emergency airway management is a high first attempt success rate with few complications. And so looking in the hospital for over 95% first attempt success in the hands of trainees, who are the people who intubate generally at our institution, with few complications. And so we've done trials and unpacked the intubation procedure to get at how do you get the tube in on the first laryngoscopy attempt. And this is such interesting data, because now we're looking at the flip side, and we're actually looking at patient-centered outcomes. And the secondary outcome just absolutely hits you in the face and says, if you care about having fewer complications immediately after intubation, that you have to intervene on, that you have to dose vasopressors, maybe give them peripherally with the risks of extravasation and other things. If you want to avoid all that, at least 5 percentage points of the time less, you might decide in medical patients to use Etomidate.
Yeah. I mean, you could just take the huge picture view and say, well, it's okay. So you got to start from some vasopressors. What patients really care about is living or dying. But I think you're right. I think from a clinician point of view and a patient point of view, you want to, as a clinician, you would want to do less things to help save the patient. And from the patient's point of view, you prefer not to need these life-saving measures following intubation. You just want it to be smooth. You want no complications and go up to the ICU. You don't want doctors saying, oh, we have to do this thing we weren't planning on, which always makes things a little more complicated. So I think you're right. I think it is a really important secondary outcome that we should take seriously when we're making the decision about which medicine to use, which I guess takes us to our takeaways, what we're going to do this. So we didn't see a difference in mortality. We saw less cardiovascular collapse when Etomidate was used. On the flip side, it's more cardiovascular collapse when ketamine was used. Again, this is just in medical patients. This is not trauma patients.
And I believe the point estimate difference in sepsis in the subgroup was even higher at 9.5.
More cardiovascular collapse with ketamine.
With ketamine,
so the difference is pronounced. Yeah, that's a good point. We didn't talk about that.
It's almost double of what it was.
So what is your takeaway then when you're in the stabilization room? When are you going to reach for Etomidate? When are you going to reach for ketamine?
So I think bottom line, if you take one thing out of this, is that Etomidate does not kill people, as what was traditionally thought. Mm-hmm. What it does for my practice in the stab room, I've traditionally always used ketamine or Etomidate. I'm sticking with Etomidate. The one caveat is pre-hospital, it's a different world. And while we're kind of split down the middle for ketamine versus Etomidate for induction, they have the paramedics can decide what they use. Is for post-intubation sedation and analgesia, we don't have a lot of good options. And if they use Etomidate, a lot of them go to ketamine for post-intubation sedation. You might use a lower dose, like 1 mg per kg versus 2. But the one benefit I do see with ketamine, pre-hospital especially, and talking about patient-centered outcomes, awareness with paralysis, which was not looked at in this trial, but is a hot topic right now. Ketamine buys you a little bit more time. I mean, picture like in the pre-hospital setting, it might just be you two, and you've got to do everything: access, lines, pre-oxygenation, intubation, blah, 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 blah. Ketamine gives you a few more minutes to get post-intubation sedation, whether that's another dose of ketamine or whatever. It gives you a little bit more time. So I think the awareness with paralysis risk might be lower with ketamine just because of its duration of action. And it is something I sometimes reach for if I might have a really, really difficult airway where I know I'm going to be maybe doing the potential to do fiber optics through an LMA or something, or you just got to be really cognizant about post-intubation sedation, especially if you use rock, which I do if I'm anticipating something anatomically really difficult.
So, Etomidate in general, but ketamine, if you think post-intubation sedation could be
select cases, yeah,
delayed or prolonged difficult airway where you don't want to be redosing things.
Mm-hmm. And I think, interesting, at our practice, I think there's variability, of course, but I think for hemodynamically, tenuous patients, a lot of our folks reach for ketamine as a first-line agent for post-intubation sedation until pressors or more fluid or whatever, and because they can tolerate something like propofol or midazolam. But it's interesting.
Yeah, this brings that practice into question.
It does.
Yeah,
it does.
All right, Matt, what do you think? Etomidate, ketamine, when would you use each? Same as Aaron, just going to copycat them?
I usually do.
Yeah, when you're intubating in the living room,
if I'm in the back of the ambulance with Aaron, that's trouble. Something's wrong. No, I mean, I've been using Etomidate for the 12 years I've been on faculty here, and I think I'm going to continue to do that. I like this study. We have the luxury at Hennepin of saying we enrolled a large number of patients in this trial. Those patients reflect our practice, and so this directly informs what we do. I think the data are generalizable. I think I can say to colleagues that work elsewhere, see these same kind of medical patients, that you're not going to have a mortality difference in routine use of either agent. But the less cardiovascular collapse, significantly less with Etomidate, I think just pushes me more to continue that practice. But we can't really extrapolate it to the pre-hospital environment. Trauma patients, which you see a lot of in our practice, can't directly extrapolate.
That was going to be a follow-up question, is do we need a trial in trauma of the same question?
I think that's a good one for Brian. What do you think?
Yeah, I mean, I think for your average, if someone who just has well, I guess head injury is somewhat of an open topic with ketamine, but I think hemorrhagic shock is one big
I'm talking
group
about
we're not fully accounting for here.
Yeah.
So someone who is really injured, getting emergency transfusion, I think that is still an open question. I'm less excited about just trauma patients in general, because a lot of them, it doesn't really matter what you do. I think they're going to be fine either way.
You need trauma patients with an injury severity score of
somebody who's pretty injured. But even if we do a study where we enroll all trauma patients, which I hope we get to do someday, to learn this question, I think we'll be able to find a subgroup that's big enough, just like we had a big sepsis subgroup, so we can answer a variety of subgroup questions as well.
I mean, because in head injury especially, cardiovascular collapse matters a lot, right? Hypotension, hypoxemia, just decreased cerebral perfusion in general, that might translate to something a lot more clinically relevant, right?
Yeah, so especially with the multiply injured patients. So, and I think what this also highlights is, this is a single drug, single dose, but what we do after intubation also matters, and that's something that obviously it wasn't a focus of this study, but I think it's something that we should look at moving forward. What's the safest way to provide post-intubation sedation so they're not aware, but we're also not harming them with sedation. So I think that's another next step.
Does this change your post-intubation strategy for sedation? You've got a hemodynamically tenuous patient.
I think,
what's your current strategy?
Historically, it was to hey, let's maybe instead of propofol, let's do some pushes of ketamine. But I think
$1 mg per kg or so.
If I do that, whatever I do now, because there's almost no drug that is completely safe. So I think whatever I do, I'm just going to do it lower dose and do it more carefully. I don't know if I have a one-size-fits-all strategy for the exact drug, exact dose, but I'm going to just be more careful and use lower doses in general, and just make sure that we're balancing perfusion and sedation so they're not aware at the same time. But I think this trial is super helpful in knowing that ketamine is just not this miracle drug that has no deleterious effects.
And just like we talked about first attempt success, which is, as Airway teachers, we care a lot about that procedural outcome. This also illustrates we have room for improvement in preventing and mitigating cardiovascular collapse, because even ideal use of Etomidate at the same doses used in the trial, we still saw that in 17% of patients. It's almost 1 in 5 patients have cardiovascular collapse. So could we have anticipated that? I think the body just cares about the blood pressure, and hemodynamics doesn't care how you get there. So that's probably one of the next avenues for research, both at the time of intubation and after. But coming back to the trauma question, I think it's really interesting, because in critically injured adults, are they that much different than critically ill adults? And why would we expect differential effects of ketamine and Etomidate in that population? And I think there are questions about equipoise after the release of the RSI trial today. Could you do that trial at our centers who enrolled in RSI 1, for example, and still expose patients to ketamine?
Yeah.
I think that's something we're going to have to keep talking about and talk about with our network.
Yeah. Well, thank you for joining this discussion of the RSI trial. I think the results are definitely going to change practice, and I'm curious to see how it's going to change your guys' practice.
Yeah, leave a comment or feel free to shoot us an email or a question.